I hope you all are sharing my slides and hearing my voice. My name is Dr. YOUSUF YAHYA. I'm working as Assistant Professor in Peds Unit 2 in the Peds Department. Today my topic is preterm babies. I hope that you might all have seen the preterm babies in the ward. You might have rotated in the ward in the third year or fourth year in the final year clinical postings. And you might have come across with the babies who are born before terms. So this is preterm babies, a totally new category that should be discussed in this term. Now, before going to discuss about the preterm babies, there are some key facts. We all know that every year, almost 15 million babies are born preterm. Preterm are those babies who are born before term. Term is defined as 37 weeks. So those babies that are born before 37 weeks of gestation are called preterm babies. And this number is rising with each passing year. The problem is that as the babies are not mature, so the complications among them as compared to the term babies are more as compared to the term babies. Now, the preterm babies' complications are the leading cause of death among children of 5 years of age, and they are responsible of almost approximately 1 million deaths in 2015. And 3/4 of these deaths could be prevented with current cost-effective interventions that we'll discuss later on. Now, across 184 countries, the rate of preterm babies ranges. It might range from 5% to 18% of babies born. It depends upon the babies are born in developed countries or the undeveloped countries. In developed countries, almost 23 or 24 weeks of babies might be able to survive. But in the underdeveloped countries, even 1 kg of the baby with a weight of 1 kg or 1.2 kg might be difficult to survive. So the rate of complication, the survival of the preterm babies differs from countries to countries. Now, in Pakistan is the number 4 among the 10 countries with greatest number of preterm births. Neonatal mortality rate in Pakistan is 41.2 per thousand live births, and it is one of the highest in the world. Pakistan has the 3rd highest number of neonatal deaths each year, which is responsible for 7% of neonatal deaths. Now, regarding the number of the preterm babies, Pakistan annually almost has 7,48,000. Such births are preterms. And this is the 4th highest among after India, which has around 35 lakh preterm births. China has 11,72,000 preterm births. Nigeria has 7,73,600 preterm births. With a rate of 15.8% preterm births per 100 live births in 2010. And with this, Pakistan remained 8th in the world and the first among Asian countries registering preterm births. The world rate of preterm birth is over 10%. As I have already discussed, that the underdeveloped countries, the rate of preterm babies is high and the complications and the survival is difficult. Malawi is I think situated in East Africa, has the highest rate of preterm births. That is around 18.1%. But the Belarus had the lowest preterm birth rate of 4.1%. So it varies upon countries to countries. It varies upon either it is a developed country or an underdeveloped country. So there's a dramatic difference in survival of preterm babies, as I already discussed. For example, more than 90% of the extremely preterm babies, that's less than 28 weeks of gestation, born in low-income countries, died in first few days of life, as opposed to this. Less than 10% of the extremely preterm babies die in high-income countries. So there's a huge difference of survival between the preterm babies. Now the problem is that many survivors If even a preterm baby survives especially in the underdeveloped countries, they might be disabled. They might have learning problems. They might have visual problems. They might have hearing problems. Inequality in survival rates around the world are stark. In low-income settings, half of the babies born at or below 32 weeks, that is 2 months early, die due to lack of feasible, cost-effective care such as warmth, breastfeeding support, and basic care for infections and breastfeeding and breathing difficulties. In high-income countries, almost all of these babies survive. Suboptimal use of technology in middle-income settings is causing an increased burden of disability among preterm babies who survive the neonatal year. Now, by having this background, now in this lecture, we will try to review the background and epidemiology of preterm births. We'll discuss the risk factors, why there is increase in chances of having preterm babies, and we'll review how to prevent these preventive options for those women at risk. We'll also discuss how we can assess the gestational age of the preterm baby. It means how we can say that even after birth, the child is born before 37 weeks of gestation. Then we will discuss about what are the complications in the preterm babies. Why do they cause problems? And then we'll discuss some of few nursing care of the preterm babies, particularly regarding respiration, regarding their temperature control, and regarding their feeding difficulties. Now, before going to all these objectives, we should know some definitions about the preterm babies. Now, initially, first we have perinatal period. The perinatal period starts from the 28 weeks of gestation through the 7th postpartum day. So babies are born, before born, they are included in the perinatal period from 28 weeks of pregnancy and after delivery till first week of life. These are included in the perinatal period. But the neonatal period starts from the delivery to the 28 days of life. So we can roughly say that up to 1 month of life, these are called neonates. Now, in the neonates, the babies who are less than 1 week of age, that is less than 7 days of life, up to 7 days of life are the early neonatal period. Is the early neonatal period, and from 8 days onwards up to 1 month, almost 1 month, these are called late neonates. Now, in preterm, again it's been divided in 3 categories: preterm, term, and postterm. As I already mentioned, the term babies are those who are born after 37 weeks of gestation. So from 37 weeks of gestation till up to the 41 weeks of gestation are the term babies. And those babies that are delivered before 37 weeks of gestation, regardless of their weight, are called preterm babies. And those babies who are born after 42 weeks of gestations, regardless of their weight, are called postterm babies. So we have got term, preterm, and postterm. Before 37 weeks, preterm; 37 weeks to 41 weeks, term; and after 41 weeks, that is after completion of 41 weeks, that is from the start with 42 weeks, are the postterm babies. And these definitions are regardless of the birth weight. Now, again, in the preterm categories, we can divide again preterm into late preterm, moderate preterm, early preterm, and extreme preterm. Now, late preterms are those babies who correspond to 35 to 36 weeks of gestation. Moderate are between 32 to 34 weeks of gestation. Early are less than 32 weeks. And extremely preterm babies are those babies who are even born for 28 weeks of gestation. So, as the preterm babies deliver, as we have got more and more extreme preterm babies, that is less than 28 weeks of gestation, the survival becomes difficult. We have got a very good survival of late preterm, moderate preterm, and early preterm. But extreme preterms in our setups, but we have got a bit, it's difficult to survive. But in other foreign countries, in the developed countries, their survival is also very good. Now, an estimated 15 million babies are born too early every year. That is more than 1 in 10 babies, and out of 10, 1 baby is preterm that is delivered. And approximately 1 million children die each year due to complication of the preterm. So we have got a very huge burden of the preterm babies that has been delivered, and we have huge problem of babies that expires because of preterm and its complications. Now, how do we assess the gestational age? Because it all depends upon the age of the baby that is been delivered. We can estimate the dates from the age of conception, so that if you know the baby is being delivered very early, so we can manage his delivery, we can manage the complication, we can intervene in these problems. Even it has been said that as the baby has been delivered very early, for example, it's been delivered less than 32 weeks of gestation, then it should be delivered at a center where there are appropriate tertiary care center, where there are appropriate facilities to deal with those preterm babies, because these are very prone to develop respiratory distress syndromes and other complications. So it has been delivered in a center which does not have those facilities, then will land into problem. So the assessment of gestational age is very important. It's important even before delivery, and it is also important to assess the gestational age after delivery also. It can be gestational age can be determined prenatally and postnatally. Prenatally, as I already said, that it can be determined by last menstrual period. It can be determined by obstetric estimate and combined estimates. But after delivery, we have to follow a system. We have followed the scoring system that is called the Ballard scoring system. And on this basis, we can say that the baby that has been delivered at 28 weeks, 30 weeks, it's been delivered after 37 weeks. What is the exact gestational age? Roughly, in 2 weeks of duration, we can say that the approximate gestational age of the baby is this one. So in Ballard scoring system, we have got 6 neuromuscular maturity criteria and 6 physical maturity criteria. And we will discuss each one by one in this presentation. Each has got some points. We'll add on these points, and when we have got total points of physical and neurological criteria, then we can easily put this points, the score system, and we can get the estimated approximate gestational age. For example, if the total point becomes 35, then it means the baby that has been delivered corresponds to around 38 weeks of gestation. This is, these are neuromuscular criteria scoring system. One is posture. As the baby has been delivered, the tone is very, if the baby has been delivered early, the tone is hypotonic. And because of the tone, the posture differs. As the baby gets mature, has a more flex positions, it's been more active, it's been taken a more flex position, baby lies in a more flex position. So if you see this baby, it means it corresponds to this picture. So we can give the score of 4 in this baby. The greater is the score, the more is we consider is the maturity of the baby. After the posture, then this is called a square window sign. We can fold the fold the hand at the wrist, flex the hand at the wrist, and see the angle between the hand and the forearm. So this is the angle, and we can compare this angle with this diagram. In this baby, it almost corresponds to this. I think it corresponds to this with this picture. It's almost, I think it's 45 degrees. So we give the 0.2 to this baby. Then after the square window sign, we can have arm recoil. In the arm recoil, what we do that, we first flex the hand over the chest and then let it go. And then we can see how much the arm recoils itself. So first we flex the hand. First we flex the hand over the chest. Then we straighten the hand and let it go. Then the arm returns back towards the forearm. This hand turns back towards the recoils back towards the chest and towards the arm. And with this recoil, we can say that how much we can have this recoil. And then again we can plot this recoil on this diagram. If suppose the arm recoils around 110 and 140, then we can have a score of 2. So if we can add on these scores, we can finally have an aggregate of the score. So we have gone through, up till now we have gone to posture. We have discussed about the square window sign. We have discussed about the arm recoil. Now it's popliteal angle. Now in the popliteal angle, when the leg is straight, we flex the thigh over the abdomen and the chest. Then with this help of the hand, we pull the leg and foot. We pull the leg and foot with the help of the hand, and just we monitor and see how much we can extend the leg at the knee joint. And with this angle, we can we have to plot this angle into the chart. For example, if we suppose in this chart the angle is around it should be around it's almost like it, or it's almost where you can plot it. I think it's around like this. Okay, no, it's around like this. So we can give a score of 5. So depending upon the angle, we give the score. Now it's a scarf sign. Now with the help of the hand, this is the elbow, this is the shoulder. We flex the hand over the elbow and then pull it over the opposite shoulder, and then see how much this elbow crosses either it crosses the midline, or it doesn't crosses the midline, or it goes away almost towards the left, almost towards the opposite shoulder. In this baby, it's almost at the midline, so we can give the score of around 3 in this child. Taken in the scarf sign, we give a score of 3. Then again in this child, this is heel to ear test. In this test, we flex the thigh over the abdomen. Again with the help of the hand, we pull the leg towards the ear and see how much we can reach towards the ear. More the preterm baby, more is the more we will be able to pull the legs towards the ear. In this diagram, I think it goes, it's up to 2. So these are the neuromuscular criteria. Again, just we have repeat the neuromuscular criteria. There are 6 neuromuscular criteria. We started with the posture, then we check the square window, then we check the arm recoil, then we check the popliteal angle, then we check the scarf sign, and then check the heel to ear test, and we aggregate all these scores. Okay? Now, after this neurological criteria, you go for the physical maturity scoring. You might have seen the newborn babies. The more the preterm the baby is, the more is a shiny skin with with busy veins visible in it. These are very delicate babies with a small weight, shiny skin, visible veins. As the baby starts to mature, the skin starts to get rough and skin starts to get thickened. Skin starts to get parchment as the baby maturity increases. Even after post-mature, if you have seen the post-mature baby, the skin is parchment-like, and in the preterm baby, it's very transparent, thin, with visible veins. In the term baby, it's a normal skin. So with just by seeing at the skin of the baby, at the look, we can say that the baby is preterm. For example, in this child, we see the skin is parchment-like. So it seems that is very well matured. We can, if we have got a parchment-like skin with deep cracking, with no visible veins in it, then we can give a score of 4. If it is crackled and wrinkled, then we can give a score of 5 also. So skin is a very good physical criteria to see the maturity of the baby. Now, another thing is lenigo. Lenigo are called the hairs that are present at the back. It's none in the very preterm babies, but normally in the preterm babies, as the babies been delivered at around maybe in 24, 23, 26 weeks of it, they have got a very abundant sort of lenigo hairs over the back, the fine hairs. But as the baby gets matured, they started to get thin. And there are bald areas in the term and the post-term baby, it's almost sparse. You don't see much in the post-term babies. So in this baby, we don't find any lenigo hairs over the back. So it's almost a bald area. So it's between 3 to 4. This could is 3 or 4. It's almost 4 in this baby. Now another physical criteria. For the physical criteria, we see the soul of the baby. As the baby is well matured, we have got a very fine creases at the foot. We have over the whole of the sole of the foot. If the baby is matured, we will not find all these creases. As the baby starts maturing, the creases increases. So with this baby, is almost all of the sole of the foot has been covered with the creases. So creases come over the entire sole. So we give a score of 4 in this child. Again, breast. As the baby's, if the baby is very preterm, then we will not find any breast buds or any breast. It is almost imperceptible. As the baby gets mature, it becomes perceptible. Then it becomes areola becomes flat with no bud. Then we have got a stippled area, a stippled areola with 1 millimeter bud. As it becomes more mature, then the areola becomes raised, and size of the bud gets increased. And in a fully mature baby, we have full areola with a 5 to 10 millimeter bud. So here it's almost a raised area with 3 to 4 millimeter bud. So we can give a score of 3 in this baby. Again, eye or ears. These are also very well established criteria for seeing the maturity of the baby. If the baby is very preterm baby, then if we can fold the ear and let it go, then it will not recoil itself. It does not have much cartilage in it to recoil itself, or it doesn't go back. It remains folded. As the baby starts maturing, the pinna, the size of the pinna gets increased. Is the curvature, the curves in the pinna, we will start to see the curves in the pinna, and then the recoil starts. If the baby is further matured, then we will have a well-curved pinna, but soft, and we can have an easy recoil. As the baby approaches term, or even in post-term babies, the pinna becomes firm and it has constant recoil. And in very well matured baby, because the pinna is very thick, cartilaginous, and the ears become stiff. So with this maturity, we can easily observe the preterm, how much the preterm baby is. In this child, as we see that if we in this child, in this baby, the recoil is not the pin has got few curves in it, few pin has got, but the recoil is not instant. It looks that it remains folded even after recoil. So we can have slow curve, slightly curved pinna with soft, slow recoil in this child, or even lids open, pinna flat. It's not flat; it's curved. So we can give a score of 1 in this baby. Now regarding genital areas, if the baby is male, then we will have to look at the scrotum and the testes. It has been said that at 32 weeks of gestation, the test starts entering the scrotum. In the male, if the baby is very thin, then we will have a flat scrotum. We do not have rugies in the scrotum, and it's very small, with no testes in it. As the baby gets matured, it starts coming in the upper canal. Test starts coming in the upper canal with rare rugi. Then starts to descend with few rugies, and testes are well down with good rugies. And in the very term babies, very mature babies, the scrotum becomes pendulous and deep with the deep rugies. Now, if the baby is female, then we have to follow this the prominence of the clitoris. If the labia major is more prominent or minor is prominent, and on this basis we can decide. Now, after having gone all these 6 physical and 6 neurological criteria, we add up all the points, all the scores that we have mentioned, we have calculated on this Ballard scoring. If the score is around 35, let's say it's 35, then the baby is around 38. The baby delivered is around 38 weeks of gestation. As the score gets more, for example, the baby is 40 weeks, then we have got the gestation is around 40 weeks. The babies, if we have got a score of 45, then baby is around 42 weeks of gestation. But if the score is less, for example, if there is a score of 20, then we have a baby whose gestation age is around 32 weeks of gestation. So this is in this way, even after delivery, we can approximately say the baby that has been delivered is correspond to that particular gestation age. Now, etiology. The cause of the preterm babies. Why we have preterm babies? The cause can be divided into spontaneous and induced. Cause of spontaneous induced premature births. As we all have in Pakistan, one of the most common cause is low socioeconomic status. If the mother is malnourished, the mother is weak, so there are more chances of delivering a preterm baby. The preterm baby and also the baby that has been delivered is IUTI, that is intrauterine growth retardation. So low socioeconomic conditions stands for poor for preterm babies and also for the small for gestation age or IUTI babies. Then if the pregnancies, if you have multiple pregnancies, one of the most important causes of preterm babies, even in developed countries and as well as in underdeveloped countries. As we have got twins or triplets or quadruplets, the number of babies increases. With the increasing number of babies, there are more chances that the labor has been induced earlier on, and we have a preterm baby. Infections. Mother, UTI is a very common infection in the mother. There are also other infections that predispose the mother to preterm labor, premature labor. Now there are chronic conditions also, like diabetes and high blood pressure. High blood pressure is more induced, is more associated with SG or IGR baby, but it can also produce if the blood pressure shoots in the mother at the time of the labor, then the mother can go into a preterm premature labor. For diabetes, normally if the diabetes is not a gestation diabetes, or it's been controlled or is not for the long standing, then we have a very healthy babies, that the polycythemic healthy babies that's been delivered. But as the diabetes in the mother, the resting is very prolonged, the diabetes is very prolonged, the diabetes, then there are more chances of having preterm, or if the diabetes is not in control, there are more chances of preterm and SG babies in long-standing diabetes. Even if the blood pressure is uncontrolled, we can have, even in short-standing diabetes, if the sugar is not controlled, then it can cause preterm baby. Placental insufficiency as indicated by unsatisfactory fetal growth. So we have more chances of having SG and IUF babies in placental dysfunctions. Eclampsia. If the mother starts having first in the delivery, obviously a mother can goes into labor and can cause preterm delivery. Antepartum hemorrhage. So if the mother has got antepartum hemorrhage, then labor is obvious. There are also genetic inheritance factors also, and some that predispose to preterm babies. And even after all these causes, we have got a lot of babies in which we do not find any cause of it. So, however, no cause has been identified in such babies. In condition, the mother sometimes cervical incompetence is very important cause of preterm babies and mothers also. So there are factors that induce delivery, the factors that causes preterm baby, and there are circumstances in which we don't find any cause. No cause has been identified. Now up till now, we have discussed what are the preterm babies, how to define preterms, and what are the category of the preterm babies. We've discussed how to assess the preterm babies. How do we know that it's been delivered before 37 weeks? What's the custodial age of the preterm babies? What are the causes of the preterm babies? Now, why it is important to know about it? Because of the complications of preterm babies. Right? Complications include, it depends upon all the systems. For example, if the baby has been delivered early, the lungs is not well formed, we can go into respiratory syndrome. We can have electrolyte metabolic problems like hypoglycemia and hypocalcemia. Obviously, infections, preterm babies, the problem faces we have a very big problem of infections because they don't get immunoglobulins or don't get immunity from the mother in the last trimester as the baby has been delivered preterm. The immune system is not that mature, so that as the baby comes into this world, he catches infection from the environment or from nursery or from the people around it, and it's a big problem. Necrotizing enterocolitis, we'll discuss about it. We can have a PTA in the preterm babies. The preterm babies can goes into apnea and bradycardias. We can have intraventricular hemorrhages during delivery. That is a problem. And obviously, if the baby is very small, the baby is delivered preterm, the babies will develop hypothermia very rapidly. And we have to be very careful at the temperature of the delivery. We have to be very careful at the temperature in the operation theater, and even in the normal labor. If the temperature is cold, if the AC is been open, then those babies goes into hypothermia very rapidly, and hypothermia is one of the major complications, causes major complications problems in the newborns. Now, feeding. As all the systems are not mature, for example, we have discussed that the lungs are not mature, the gut is not, so with other systems, gut is also not mature. Not only the gut, the feeding requires sucking and swelling. The sucking and swelling reflex just starts to develop after 32 weeks of gestation, and sucking after 32 weeks and swelling up at around 30 to 34 weeks of gestation. So if the baby's been delivered preterm, it's very difficult how the baby is to be fed. So normal time babies, in the normal time babies start breastfeeding, but if the baby is 1 kg, if the weight of the baby is 1 kg, is been delivered 28 weeks, will not be able to directly breastfeed the baby. Then we have to think about how to manage the feeding in a newborn baby. Now, regarding chronic complication, the baby has been admitted in the nursery. They have got a high flow of oxygen. Baby has been ventilated for a long time. Then the lung got damaged, and we can have a bronchopulmonary dysplasias. Even oxygen sometimes oxygen can also cause problem because of increased amount of oxygen given to the preterm babies. We can have retinopathy of prematurity with subsequent visual problems. We can have hearing impairments in the newborns, in the preterm babies. Then neurologically, they are not very well matured. They have higher rates of cerebral palsy. They have higher rates of learning disabilities. They have higher rates of attention deficits and behavioral problems in the preterm babies. So complications rate increases with decreasing gestational age. Morbid mortality patterns in the preterm babies. Now, this study has been done in Pakistan, in Rawalpindi, and it's been published in 2016. It shows that almost 119, almost 200 preterm babies were included in the study. The mean gestation age was around 32.48 weeks. The birth weight was around 1.795 kg over 1795 grams, approximately. Out of these babies, almost 16% babies were expired in this setup. So it's a very huge, very high number of babies that have not been able to survive. More expiries were observed with gestational age less than 30 weeks. So babies that has been delivered after 32 weeks have got a better, in this study, has got a better survival rate as compared to babies has got who's delivered before 32 weeks of gestation. So in this setup, birth weight, babies who's got a birth weight of more than 1.5 kg at a better survival rate. Now, the basic problem they identified that is that of hyaline membrane disease. You know that as the lungs as the gestation age increases, the lung starts to mature, lung starts to produce surfactants. As the preterm baby is and with the preterm babies, this phenomenon doesn't happen. So the lungs have not been matured, they've not been able to breathe, that the alveolus has not been able to expand at the time of birth, and we have a respiratory distress syndrome at birth in the preterm babies. This hyaline membrane disease accounts for 40% of expiries, followed by sepsis. We already discussed infection, a very big problem, and then necrotizing enterocolitis in 12.5%. Again, the commonest complications that was observed in the study was sepsis in 28%, 20.6% of babies. Then we have got hyaline membrane disease, 20.5% of babies, necrotizing enterocolitis in 15.5% of the babies, and then we have got neural jaundice in 10.6% of babies. Necrotizing enterocolitis and hyaline membrane disease were strongly associated with low gestation age and low birth weights. Now, one or two, I will discuss one or two things in slightly more detail. Now, respiratory distress syndrome. I just pointed out that lungs of the preterm babies lack adequate surfactant. Surfactant is the material, is the substance that helps to expand open up the alveoli and expand the alveoli when the baby breathes. It reduces the surface tension of the alveoli, so that when the baby breathes, the alveoli gets open. The lungs are non-compliant. If the alveoli has not been opened, the compliance of the lung is not good. They do not expand easily and hard to breathe. They will be prone to atelectasis. The alveoli will collapse, and for this increased energy required to breathe, and breathing becomes difficult, becomes very difficult, and it might be slow, it might be labored, and it's very rapid also. So with this baby, so those babies will not be able to maintain the oxygen saturation at particular level. we have to make at the time of the birth, saturation is of the term babies, even the babies are not, but after 5-10 minutes of birth, they usually achieve the saturation. After 10 minutes of birth, they usually achieve a saturation of more than 95%. But those preterm babies will not be able to do this because the alveoli has been collapsed. Their perfusion and oxygenation doesn't matches very well. So their oxygen saturation then drops. They have got hypoxia and they might have hypocapnia also. So those babies need to resuscitate. Sometimes they need to resuscitate at the birth. Those babies need to give surfactant at the birth. Those babies need to give humidified oxygen at the time of the birth, so as to maintain the partial pressure of arterial oxygen between 50 and 70 millimeter Hg. That's around 90-95% of oxygen saturation. Or we need to give high humidified, high flow nasal oxygen. Even sometimes we need to give nasal or continuous positive airway pressure. Sometimes we need to give CPAP to those child. Mild preterm babies, mild RDS babies respond to the CPAP. That is continuous positive airway pressures. In our setting, it's been given, we call it bubble CPAP. And even if the RDS is severe, it's not then we have to put it on mechanical ventilation also. In we have to fully ventilate newborns also. If the baby develops respiratory failure or persistent apnea, then we need to give mechanical ventilation for the child on ventilator. So this is how we give the oxygen with a nasal cannula. This is how we give the oxygen through the continuous positive airway pressure. That's called CPAP. This is the child who's been put on ventilator with this airway to pass the ventilator tube and connect the endotracheal tube with the ventilator. This is a baby on ventilator. Now, surfactant replacement therapy. Now, as we have already discussed that as the preterm does not have a surfactant, so even if the baby has been delivered very early, for example, has been delivered at 26 weeks of gestation or before 28 weeks of gestation, and so we have to arrange a surfactant, and we have to prophylactic to give the surfactant. Immediately after birth, we have to pass endotracheal with surface so the baby's lungs get expanded. So with improved alveolar oxygen, it causes improved alveolar arterial oxygen gradients. If we go to surfactant, then it reduces the ventilator support, increase pulmonary compliance. So normally those babies who are delivered 28 weeks of gestation develop RTS. Then they need then and weight is below 1.2 kg. They need surfactant. Now, necrotizing enterocolitis. As the gut has been not matured, so devastating inflammatory process that can occur anywhere in the lower GI tract that causes necrotizing enterocolitis. Those at the lowest gestational age are at the highest risk. Even a formula feed is an additional risk factor. So enterocolitis is very important in the preterm babies. If the baby has been delivered, what we plan is we plan to start the enteral feeding as early as possible. But we try to start with the mother's feed. If the baby is been able to tolerate the feed, then we start with the colostrum of the mother. Colostrum has got a very good pro-traumatic factors, and it has got immunity, immunoglobulins, and all the things, and it helps to mature the gut also colostrum. But otherwise, the dystoph feeding, the spinal feeding doesn't have all these helpful factors. So it's been advisable as the baby's been delivered, it's been able to give it colostrum to the baby. That will be very helpful. If you start with the especially formula, then the chances of the necrotizing enterocolitis gets increased. In approximately 40% surgical exploration, if the baby develops necrotizing enterocolitis, then approximately 40% surgical exploration and excision of necrotic valve loops. So feeding is very important. Prevention. And how we can prevent the preterm babies. It has been said that the administration of antenatal corticosteroids to women before 37 weeks of gestation significantly reduces the incidence of overall mortality, admission to NICU, need for ventilatory support, incidence of IBH, that is intermittent hemorrhage, NEC, necrotizing enterocolitis, and neurodevelopmental impairment. So, if we want to want the baby to if we want that the baby's lungs gets mature, that we need to give corticosteroids to the mother. Usually the 3 doses being given 24 hours apart before 24 hours before delivery. Essential extra newborn care. Now again, I'll just discuss a few things about the thermal regulation. The very teen babies are not able to keep their temperature, to keep their body temperature, to maintain their body temperature. They don't have enough fat, they don't have enough skin, they don't have enough energy to keep their temperature at a normal level, at a neutral thermal environment. So, as the baby has been delivered, what we do that we usually we deliver the baby, we receive the baby in the normal 2 wrapping sheets. Dry the baby, if the wrapping sheets is been wet, then remove that wet wrapping sheet, right again in wrap the baby in the dry wrapping sheet, put the baby in under the warmer. Even in very preterm babies, it has been said that even to cover the baby from head to with the plastic sheath is been recommended. But for the term babies, it has been said in preterm babies, it has been said that the kangaroo method has been proved to be very effective in maintaining the body temperature of the newborn, in maintaining the temperature of the newborn. And what we do in the kangaroo method is that we keep the baby with the mother's chest and breast directly with the skin-to-skin contact, so that the temperature of the mother, the warmness of the mother keeps the baby warm. Then we have got other options like bleeding warmers. If the baby has been admitted in nursery, we can keep the baby in incubators. With this clinician hypothermia, then feeding supports is very important. The newborn babies. When we receive the baby, it should be received as in an aseptic. We have to in aseptic manner. For example, we have to when we enter the labor room to receive the baby. If we enter the operation theater or to receive those babies, that we have to wash ourselves as we have to go for the surgical operation. So even in nurseries also. Even not only in deliveries, even after in nursery, in normal handling also, this infection prevention is very important. And the most important factor in the infection prevention is washing. We should not send any newborn without washing our hands. So washing is a must before touching a baby. We can easily transmit, we easily get infection to the baby, and we have to be very careful for this. Recommendations. Now, WHO technical solution to the adoption of 10 main recommendations covering one of the important thing is antenatal corticosteroids. I've already discussed. So those babies who have been expected to deliver preterm. And in those babies, the mothers has been given corticosteroid to get the lungs of the babies get matured. Tocolysis is used to prevent the preterm babies. Magnesium sulfate has been used. Antibiotic prophylaxis if the preterm is very preterm, they have high chances of infection in the neck. We got admitted in the nursery, very high chance of infection, catching infection. They have been manipulated at the time of deliveries, so sometimes they need to give antibiotics. A mode of preterm babies is for the mother. Nowadays, the cesarean, one of the causes cesarean delivery because cesarean had always been conducted 1 or 2 weeks earlier. So with the increasing of cesarean deliveries, we have got a greater increase in number of the preterm babies. Kangaroo method can again discuss that the kangaroo method is one of the most important intervention in maintaining the normal thermal environment of the baby, normal temperature in the normal skin temperature, normal body and core temperature in the baby. So it's very recommended method. Again, we discuss about the plastic wrap. So if the baby is very preterm, we can wrap the baby in the plastic sheet so that it does not loses heat from the body. If the baby has got a mild IRTS, IRTS, respiratory stress, then continuous positive air pressure CPAP is one important way of getting it recovered, in supporting the baby, in supporting their lungs, in supporting their oxygen level in the baby. Surfactant has been used. If the baby is very term, we use surfactant to open up the alveoli. And oxygen therapy if they need it. So these are the few recommendations that have been used nowadays to prevent the complications and to manage the complications in the preterm babies. Now, this is SABI. These babies were delivered at Sharp Mary Hospital for women and newborns. A baby born weighing just 245 grams, almost 8.6 ounces, and this is believed to be the tiniest on record to survive premature birth. She has been discharged from hospital in the US. Baby Sabi weighed the same as a large apple when she was born at 23 weeks and 3 days in December 2018. So this is a difference where the baby has been born. He's been born in development days, underdevelopment, development days. Just see that the baby delivered at 23 weeks with a weight of just around 245 grams. Then they were able to save this baby. This is the same baby. This is called smallest baby ever to survive. According to official tiniest baby registry maintained by the University of Iowa, after a nearly 5-month-long stay in the Sharp Mary Birch Hospital Intensive Care Unit, Sabi went home and in mid-May 2019 as an healthy, happy 5-pound infant. This is the baby. So survival doesn't only mean that the baby survived, also means does not have any complications with it. So now I think I made few questions for you. Let's see how much of you answers these questions regarding this presentation. I try to unmute you. First is what is one of the cause of increase in women's risk of giving a preterm premature delivery? What you think? Could it be multivitamins, first baby, multiple pregnancies, obesity? What causes preterm? Simple. What causes preterm baby? Out of these 4 options. Now I've unmuted all of you. Anybody would like to answer this? What is the cause of it? Anybody would like to share their view? Anybody want to answer can unmute your and answer it. So multiple pregnancy. The key is multiple pregnancy. The second one is, what is the best method for providing warmth to the well baby immediately after birth? Is it radiant warmer, kangaroo method, heater, incubator? So we have already discussed kangaroo method is the one of the most important method in maintaining the temperature in the term babies in the well. Another one. When will be the birth is considered preterm, premature? 35 weeks of gestation, 36 weeks of gestation, 37 weeks of gestation, 38 weeks of gestation. The answer is before 37 weeks of gestation. Before 37 weeks of gestation is preterm babies, is premature baby. Now, what is the neonatal mortality rate of Pakistan? Initially in the epidemiology, I discussed in the key facts, then during the neonatal mortality rate of Pakistan, it is around 41.2%. It's around, the answer is C, it is 41. 41. It's at least 41.2. What is the most important complication of preterm baby? Is it cardiac failure? Is it transient tachypnea of newborn? Is it respiratory syndrome? Is it mucous aspiration? The answer is respiratory distress syndrome, that is IRDS. Because of the deficiency of the baby's term delivered preterm, it has got a surfactant deficiency and causes respiratory distress syndrome. Thank you very much.